Hello, my name is Karina Granda. My topic is adjuvant chemotherapy plus radiation for locally advanced endometrial cancer.
Adjuvant chemotherapy. Adjuvant chemotherapy is a field of fighting cancer that combines different forms of healing. Chemotherapy and radiation, or chemotherapy and surgery, are used together. Chemotherapy is generally used after any known form of cancer has been removed surgical or by radiation. Adjuvant chemotherapy targets the destruction of hidden cancer cells that still remain and are undetected. Use adjuvant chemotherapy. Adjuvant means additional. Adjuvant chemotherapy is given to patients after initial treatment when the doctor estimates that there is a high risk that the cancer may return. Use breast cancer, colon cancer, testicular cancer, ovarian cancer, lymphomas, lung cancer, pancreatic cancer.
Hello, my name is Tafaya Headed, and I'm one of the breast cancer medical oncologists here at Mayo Clinic. And I'd like to talk to you about adjuvant therapy for breast cancer treatment. Adjuvant therapy is a word used to describe medicinal treatments that we give to women, sometimes before and sometimes after their definitive breast surgery for early stage breast cancer. And that would be stage 1, 2, or 3 breast cancer, and it also includes inflammatory breast cancer. So adjuvant therapy can also be referred to as systemic therapy, and we call it that because it's treatment that gets into the bloodstream and circulates throughout the body. Adjuvant therapy may be given as a medication through an IV, sometimes by injection, and sometimes by pill. Again, the goal is to get treatment that gets into the bloodstream and potentially kills any breast cancer cells that may have gotten away before the breast surgery. So to understand how adjuvant therapy works, we must first understand why we think breast cancer recurrences happen. It's a common misconception that some women have that doing breast cancer surgery and or radiation treatment to remove the tumor and sometimes positive lymph nodes is enough. But unfortunately, we've learned through experience that it's not enough for all women. And some women do go on to endure a relapse of their breast cancer. And sometimes that relapse may be incurable, and that is why some women do ultimately lose their lives to breast cancer. And we believe that the reason breast cancer recurrences happen is that prior to the breast surgery, that some breast cancer cells break off from the main tumor, get into the lymph and or blood vessels, and spread to other more distant lymph nodes or other organs. Sometimes it's just a handful of cells that get away. And yet these small cells, sometimes microscopic, have the capacity to be turned on again and grow and cause the breast cancer to come back. Sometimes that happens months or years, sometimes even decades after the original breast surgery. But when we do a biopsy and look under the microscope at these breast cancer cells, they look identical to the original breast tumor the majority of the time. So we think one way that we can get rid of this microscopic disease that is spread before the breast surgery, that by giving medication that gets into the bloodstream and circulates throughout the body, we can kill the cells that may have gotten away. And we think this is how we help prevent breast cancer relapse and improve long-term survival. So to summarize, we believe that the benefit from adjuvant therapy comes from the riddance of any microscopic disease that may have escaped before breast cancer surgery. We again believe this is why we help prevent recurrences and improve long-term survival from breast cancer. The absolute magnitude of that benefit is something you can talk with your provider about, as it may vary from one woman to the next.
Radiation for locally advanced endometrial cancer. Conventional treatment includes surgery to remove the cancer and determine each stage. See information below. Sometimes this is the only treatment necessary. A rigorous follow-up is then done to watch for any signs that the cancer has gone black.
In October of 2016, I started bleeding, and I knew that there was something wrong because I hadn't bled in quite a while. I called Dr. Sarah Wagner and made an appointment.
And we evaluated her with ultrasound and biopsy, which both of those tests were absolutely reassuring. Everything looked really good. So we decided to watch and see if the bleeding recurred, and it did. And so for Maria, we decided to go ahead and proceed with hysterectomy. We removed Maria's uterus. We asked the pathologist to take a look at the uterus prior to finishing her surgery, just to be sure that I wasn't missing a cancer that had been missed on the biopsy. Turned out that there actually was a cancer in the uterus that the pathologist identified.
That's when she called me in to do the surgical staging. With the staging, you can either be at low risk, which usually requires no additional treatment. This patient turned into what we would call high intermediate risk, because it had grown more than halfway through the uterine wall. Those patients, we feel, benefit from some local radiation.
I told them I wanted them to be aggressive, and then I proceeded to have 4 rounds of the radiation.
What we look at for radiation is there a risk of it coming back? And if there is a risk, where would it come back most often, and what can we do to prevent that? So for Miss Liberty, she had an intermediate risk cancer, which means most of the time it would not come back. But sometimes if it does come back, the most common place for it to come back is right at the top of the vagina. It's called the vaginal cuff. And through various research, including some of the trials we've done, it shows that by giving radiation just to that area, you significantly reduce the risk of it coming back with very little toxicity.
Her prognosis is excellent. I mean, with the radiation, her risk of recurrence is on the order of 1 or 2%.
Communication back to me has been just something that really makes me happy to work with these other doctors as well. I hear back from them as soon as they evaluate the patient, as soon as they see the patient. I receive communication from them.
I think it's a special center not only for this type, but pretty much all cancers. And one of the things that makes us truly unique is we really do have multidisciplinary care, which means I see the patient with my collaborators. The ability to see the patient together, interact together with the patient, do exams together with the patient, I think raises a level of care that is unmatched.
I've had such a positive experience with all 3 doctors. It was really great.
Gynecologic tract. Radiation therapy can be used in cooperation with surgery. In many cases, radiation therapy is the primary treatment, often combined with chemotherapy, which may make it more effective.
Radiation therapy is an invisible X-ray beam that travels through the body, and there's no pain associated with it. The X-rays are applied to the area that we are trying to target, and once that process is done, the treatment for that day is over. We know that cancer recurrence can generate from just one cell, and that's the premise behind using radiation after surgery.
First couple doctor's visits that I actually went to, I cried the whole time. You have so many things running through your mind. What stage is it? How bad is it? Can it be cured? What if I don't make it?
Many patients, whenever they get to see the doctor, their mind goes blank. So bringing somebody to the doctor with them always helps. They have another person who may think of a question that they wanted to ask, but then just forgot whenever they saw the doctor.
I'm gonna let you have a seat on this table, and I'm gonna cover you up.
In order to deliver radiation therapy carefully and to know that we're delivering treatment to the area at risk, we will do something called a simulation prior to radiation. This is a process whereby we'll either do x-rays or CAT scans, even occasionally MRI scans that allow us to visualize and see a patient's anatomy and the position of their organs.
With GYN cancers, the immobilization devices that are used are to be able to keep their legs in the same spot every day to make sure that they don't move their legs during treatment.
Certain marks will be placed on a patient's skin, and we will use those marks and lasers in the treatment room every day to verify that the patient is lined up in the exact proper position.
After the patient has all of their imaging done, we bring those images into dosimetry and we start the treatment planning process. The physician contours the target and we start planning with beams and putting the dose on the plan.
There are a number of different radiation modalities that are used in the treatment of female malignancies. We have external radiation, and that's where you bombard a tumor with a very, very strong X-ray. You can also use internal radiation therapy, which is usually delivered by a technique called brachytherapy, which is where you will place radiation, for example, into the vagina or within the uterus to place a radioactive source very close to a tumor and therefore reduce doses to the surrounding organs. Oftentimes, external radiation therapy may be combined with brachytherapy, although brachytherapy can also be utilized on its own. There have been studies that demonstrate including brachytherapy can improve cure and reduce side effects comparing to delivering a higher dose with just external radiation alone. Brachytherapy is often a source of anxiety for a patient. Some patients in some facilities may have general anesthesia. Others may have a spinal, which can numb the lower extremities and lower part of the body. More commonly in the United States, patients may receive some form of sedation or mild sedation, or even just pain medications alone for the procedure. Patients will have some form of imaging, during which time the physician, with the help of a physicist or a dosimetrist, will determine where you need to place the radiation to be most effective. As part of that process, we'll determine what surrounding tissues need to be protected from radiation exposure. We'll spend a couple of hours working together to try to formulate a plan that can deliver that radiation in the most effective way. Thank you. So let's get it transferred over to QA. All right, thank you.
Conclusion. For women with high-grade tumors, radiation is likely to be recommended after surgery. Vaginal fracturing, BV, pelvic radiation, or both can be used. Some younger women with early-stage endometrial cancer may have their uterus removed without removing the ovaries. This prevents menopause and the problems that can arise with menopause. This also encourages. Conclusion. For women with high-grade tumors, radiation is likely to be recommended after surgery. Vaginal fracturing, BV, pelvic radiation, or both can be used. Some younger women with early-stage endometrial cancer may have their uterus removed without removing the ovaries. This prevents menopause and the problems that can arise with menopause. This also encourages the chance that the cancer will come back, but it does not make you more likely to die from the cancer. This is